Are there specialties with the flight staff as well then?
Yes.
So certain calls, like they'll pull you instead of a different name?
Yes. So the way, I'll just kind of give you a brief kind of deal on how Lifelight functions as a team, which Lifelight is kind of a unique flight team because we are the only one that has specialty teams. There are a lot of teams that just cover the whole gamut. They do neo, they do peds, they do adult. Lifelight is we work in specialty teams, and so and our staffing model kind of changes a little bit throughout the day depending on time of day and kind of how it works. But a typical team for us is a nurse paramedic for the adult teams, and then the neonatal pediatric specialty teams fly nurse, and we fly a newborn ICU nurse with a pediatric ICU nurse, and then anytime we have a pediatric call, then the ped takes lead, and the neo, we're cross-trained when we get hired with Lifelight, we kind of do cross-training for pediatric or neonatal ICU. And then, so when there's a pediatric call, we go and back the peds nurse who's the lead, and then when there's a neonatal call, then we take lead and the pediatric nurse backs us.
So you never take turns flying?
We always fly together.
No, like driving.
Oh, no, heavens no, no one wants me to.
So the pilot has no medical training for the most part.
No, I am not, no, don't.
I don't know.
I'm like directionally challenged, like, and I'm not that great of like,
how do they,
don't give me,
how do they find you?
All of we have pagers, and just how they find, right? We have pagers, we're all usually there together, so we're like in the hospital, so Lifelight, since we're in-house teams, we're like hospital based, and we're not like in units working or anything like that. It kind of is like we have our pagers, we have our phones, we have our radios. When there's a call, tones go off, and they tell us what the flight is, and then depending on the information they page, we know who goes on the flight and what equipment we need to gather, and we start getting all of our equipment and that, and then even the team that didn't get paged comes and helps everybody get loaded so we can go quicker. Then we meet everybody at the aircraft and
It's more like paramed where they just sit there and take a call.
Well, no, that is us. We're there. We're just in the hospital based until we get a call. So
it's
we have.
like being at the fire station.
I say it's similar to firefighter style. We have like a room that we have like sleep rooms in an office and a living room and like quarters with all of our equipment.
At the hospital.
But you don't make
at the
rounds
hospital.
or do you?
No, we
Okay.
don't. When we're at Intermountain Medical Center, we help back like the EAV team. They'll call us for hard IV sticks and things like that. Occasionally at Primary Children's, they will also just to kind of help out. A lot of times we'll roam, and if there's a ton of stuff going on, we'll we've had like nights in the PICU where they're like getting slammed, so we'll just go down and like, hey, anybody need an IV? You want us to, whatever. So, because a lot of us came from the units there too, a lot of us, that kind of is our second like home, so we still, we get to know people, and so yeah, we're roamers. We kind of roam around and hang out. So.
They just help out.
Yeah, just kind of helping out with whatever. We'll help like unload other patients. We'll, but we have enough paperwork and other tasks and things like that too. We can stay pretty busy, but we are just basically.
So you're dedicated just for that? We're
dedicated just for Lifelight, so yeah, that trumps all else.
How many calls do you normally run?
It totally depends. So we just came out of Winter Surge, and Winter Surge for the Neo Pediatric team is like a madhouse because every kid is sick and every kid needs to be flown. So when we're in like the height of our like Winter Surge, we call it like RSV season, we'll do anywhere from averaging probably 3, sometimes 4. I mean, 4 is pushing. If you can finish 4 flights in a shift, that means you were really quick on your flight. But probably average 1 to 2 a shift. Like I worked last night.
That's a 12-hour shift.
A 12-hour shift.
Oh wow.
So the neonatal pediatric teams are based out of Intermountain Medical Center, and then there's a neo pediatric team based at Primary Children's Hospital. During the day, there's a pediatric paramedic adult nurse based at Utah Valley. So during the day, they fly pediatric paramedic or pediatric adult nurse. And yeah, so we're the smallest team with some of the highest volumes. So that's fair. We tend to stay busy. So and for a long time, AirMed started their neonatal team about 2 years ago. And before they had a neonatal dedicated specific team, we were the only neonatal team in the state.
Wow.
So
I was gonna say, how long are your flights typically to and from?
it totally depends on where we're going. Because Lifeline covers long range too, because
Yeah.
we have rotor, fixed wing, and ambulance, we'll cover anywhere. So like I took a kid from Primaris to Stanford Children's last week.
Oh.
So, you know, we
That's
flew
in
into San
California.
Jose, California. You know, so we're talking a 2-hour flight. The week before, we did a kid from St. George to Phoenix Children's.
Yeah.
You know, we cover Wyoming, part of Idaho, part of Nevada. Where else?
Montana.
Montana. It's like I'm forgetting a state. And Montana, we're the regional referral for all pediatric patients because they don't have pediatric ICUs. And we're the only ECMO center, the heart-lung bypass machines. So any kids from those areas that need to come in for like heart-lung bypass, those really critically ill kids, we go get. So, and we'll really go anywhere. We did last year, we did several, they contracted with Alaska. So we were going to Anchorage and getting kids that needed surgery, bringing them here. We'll really go anywhere, but our typical pattern is those 4 states. So we'll go rotor anywhere within 250 miles, and then we fixed wing anywhere other than that. So like last night I went to Logan last night. Like, yeah, so.
And they've
like,
got a jet.
yeah, and we have Lifelight just got a Learjet, so we can do longer range transports, which
Right.
saves us a lot of time and we love. But so the intent is to be able to do longer air transports. So yeah, like I think they're dropping a few. We do share that with Intermountain Donor Services, so they use it for organ harvesting and things. We share it with them, so they'll use it and then we cross use it. So.
Because AirMed won't typically go out of the state, right?
They don't, and I don't know AirMed's program that well. Maybe John knows. They're usually mostly rotor based, as far as I know, and don't usually go out of state. Is that correct?
Yeah, they've got, I think, 2 fixed wing aircraft. I think one's in Rock Springs and one's here.
Yeah, and so we use it for adult and stuff, but I'd say because there's only one children's hospital
Right.
and there's multiple adult facilities, and because pediatric medicine is such a specialized service, we probably do a lot more longer range transports because there's just not the resources available like there are with adult ICUs. You know? So there's more trauma centers for adults than there are specialty hospitals for kids. So just by that nature alone.
Do you guys ever not land because of weather? Or like you won't even take off because of weather?
So then I worked on Saturday night and Logan, they thought they'd be good to go into Logan. They got up to Brigham City area. The whole canyon was sucked in. They couldn't make it through. They actually ended up doing a landing in Brigham City, having EMS go across ambulance, meet them at Brigham City, and then they drove through and got the patient and then brought him back down, met the helicopter again, and then flew.
Oh, wow.
So we'll really do whatever, but we do have pretty strict weather restrictions.
Yeah.
And before every flight, our pilot checks weather and says if we're good to go or we're, whatever. We will occasionally run into weather on the way and turn and go back, but most of the time they're pretty good at knowing what we can and can't fly in. So our aircrafts now, we just started with our helicopters, have what's called IFR, which means that they can fly even when we can't. Helicopters usually go by visual flight, but with this they can fly through in the clouds, and they just have a designated flight pattern, more like a fixed wing aircraft. So we're doing that now with our rotor wing, which has made it so we can take helicopter flights in a little bit worse weather. But we're still really cautious, and after the Lifelight crashes in 2003, they are extremely, safety is not overlooked and very, very.
So is it one of those you all have to agree that you're going to fly?
Yeah, and we always say 3 to go, 1 to say no. If anyone at any point ever feels comfortable, no one questions it, we turn around and go back. So, and a seat can just be like, I have a bad feeling about this. Okay, we're done. So.
And it's kind of funny that way too, because there's been times when I've been going, I don't know, it's getting kind of dicey, and I'll say, I think we oughta, and somebody else is talking at the same time going,
Yeah.
hey, we gotta.
Yeah, I would say, it's like one of those, like, we follow our gut kind of, you know, obviously our goal, and we want to go to the patient, right? We want to help people, that's the nature of what we do, right? Like, we don't want to be like, I don't feel like it today, I'm not going to go help somebody. We know if we're going, it's critical, they need us, so we don't take that lightly, but we also take our safety extremely seriously. So.
Just with that, see, you're like the neonatal and pediatric, and then I guess is there just one other team that's the adult response, or is there multiple other specialties?
Well, so we have, in-house based, we have the adult paramedic and the neonatal pediatric team, but then we do have other subspecialties that are on call for us that can come in and help facilitate specialized transports. We have perfusionists on the LifeFlight staff who can come and help us take adult ECMO patients. We can actually transport with patients on ECMO to other facilities. So if we get a patient like that, we have a perfusionist come in that goes on the flight with us, who's on LifeFlight staffed and comes to all of our trainings, that's not an in-house member. They usually work in the hospital as a perfusionist and then are pulled on call for LifeFlight. The same thing with respiratory therapists. We have pediatric respiratory therapists that we take with extremely critical pediatric respiratory things. Kids that are like kind of on that teetering edge of ECMO a lot, or a really difficult, complicated respiratory illness. And then they have adult RTs also that come in and can help if you have a complicated respiratory patient. But because they're on call and it takes some time to get them in, most of the time, I mean, we're trained and proficient at running our ventilators, intubating, ventilation management, pressure management, all of those things. But there are those times when you run into a specialty patient that it's worth the time delay to get the right people for the patient. So
You have a high-risk OB team.
Oh, yes, sorry, and a high-risk OB team that does, pregnant people. And they are, the high-risk OB team is also, so they are working in labor and delivery. And if we get a high-risk OB call, they come out of the unit. So at IMC they're working, and they just have a system where the charge nurse backfills them and they come with us, and then when they go back, they just go back to the unit. So they're not in-house just like we are waiting for the call, but they are available to us to pull quickly if we need them.
A lot of times they'll send like a high-risk OB team, and they might send like Lindsay as a neonatal specialist.
Yeah.
Especially if they've got like twins or something.
Yeah, if there's any thought that if there could possibly be a delivery on that high-risk OB, and there's very stringent rules for transporting laboring patients, the guidelines are pretty tight on that. They'll take a neonatal nurse with them, and usually an adult nurse to be the ACLS backup, because really you're transporting two patients. And so then we'll do a 3-person team. Those specialty patients will do 3, we typically fly 2 people. Those specialty transports will do 3.
Do you ever have surgeons or anything go with you to do kid surgery?
They have before. It's not a common practice, but it's not never been done. They've had kids before that have had cardiac defects. If you've ever heard need a Rashkin, where they just need a septum pulled, and it's critical. I mean, they're not getting blood flow, they're hypoxic, and long ranges. We've actually taken surgeons from primaries with us to do the procedure at the bedside at the referral facility to get this patient more stable, because it's time critical. But it's not our standard practice.
I know AirMed, I saw a commercial not to compare you to it. They were doing field amputations and bring in a surgeon.
Yeah, and they can have all the amputations they want.
Yeah. Imagine you don't want those.
So, no, I personally don't want anyone big. So, but they offer specialty thing. I mean, each team kind of has their specialty thing, right? We have the pediatric nurses. AirMed has, they have the burn unit there, so we still transport burn patients or the amputees and things like that. But we kind of all have our thing. I mean, I personally think we're still the best, but I might be biased. So,
Yeah,
but yes,
they are the best.
yeah, and John will back me. So, but with that, and this is perfect. I want this to be super interactive. Let's talk it out, go through it. we've got like a long lecture time, and I don't want you to be bored, so
I was gonna say, well, we'll let you get to teaching eventually.
No, this is great. Let's go.
We've stalled enough, everybody's here.
Perfect. I like it. So, okay, so today we'll be going over neonatal resuscitation. Also, like, if you guys, if I'm covering stuff you guys know, just raise your hand and be like, hey, we know this, please stop. Like, it's something. So, there we go, forward. So, yeah, well, this is kind of what we've all been talking about. So we all work together, you know, all EMS personnel to get patients the best, the right care, and the fastest care possible. So with neonatal resuscitation, so these are just statistics for you. So to kind of give you a look at what we're looking at. So 10% of newborns will require some sort of assistant with beginning to breathe at birth. So if you think 1 in 10 babies needs a little bit of help at birth, it's actually a pretty good number of babies, you know. I mean, it's not super common, but 10%, you're going to see this especially in high delivery areas. Utah is a high delivery area, in case you didn't know. But because Utah is a high delivery area, we do see more neonatal resuscitations. We have really busy NICUs. We have a lot of NICUs. We have a lot of, you know, specialty nurseries and things like that with neonates. So just requiring assistance to breathe can be anything, just a couple bags, to needing full intubation, to any of that. 1% needs extensive resuscitation. Like, we're talking epi, chest compressions, all of that. So the number of babies that come out and actually need chest compressions, intubation, like very critical life-saving measures are pretty slim, right at birth. It's usually a little further down the line, but we're talking like a delivery happens, chances are you're going to be pretty good on these kids. So if you think 90% of babies make the transition just fine, you know, you don't see it often, but when you do, let's know what to do. So, antepartum risk factors. You guys had an OB lecture already? Okay, so we'll just touch on this pretty quickly. If you have any questions on it then, since you've already had kind of an OB lecture, then let me know. Otherwise, we'll just kind of go through this. So, premature rupture of membranes or bleeding is a risk factor, right? Or water breaks early for some unknown or known reason. Maternal diabetes, which just always complicates things because those kids are getting pumped full of sugar. They're getting giant. They explain like diabetes and stuff to you with babies. They're giant, their hearts get sick, the babies get sick. Actually, the kid I transported last night was a glucose, we call IDM, baby infant of a diabetic mom. So this kid was 32 weeks gestation, but weighed almost 7 pounds. So we're talking these babies are fat. And when they come out and they're glucose, because they've just been getting fed all that sugar, right? It's like, for lack of better terms, like the junk food diet, right? They're just getting tons of sugar, and they grow and grow and grow and grow. And a lot of times, moms with diabetes, their babies are premature because their bodies just can't facilitate these huge babies. The biggest baby I ever saw was like 13 pounds at like 39 weeks, and ended up with like nerve injury because they got stuck in the birth canal. Imagine that. It's not normal to push out that big of a baby. But the mom was probably like 5'2", uncontrolled diabetes, you know, and it can cause a lot of complications. And then the thing that a lot of people don't think about with these kids is how sick their hearts get, because they're pumping that flow. Their hearts don't pump super well. They start getting right-sided cardiomegaly, and then they come out and they're fit. And as long as they're in mom, they're doing okay, right? She's giving them sugar, she's circulating for them. They come out, the newborn physiology happens, and then these kids are like, whoa, we can't pump all this. We can't maintain this glucose. We can't. So their glucoses drop, their hearts get sick. They also have a higher risk of having immature lungs. I don't know the exact physiology behind that, but they usually have sicker lungs than normal.
Mainly caused by the mom not taking care of herself.
So moms that have that's why it's so important if you're pregnant and diagnosed with gestational diabetes, being super strict on those sugars. And I think there's a lack of education, people understanding like just how sick it can make your baby if you're not keeping those sugars in good control. Like this mom, she's a type 1 diabetic, so she's been dealing with this her whole life. Her A1C, she was actually kept in fairly good range. So even with like good, fairly decent control, she, this baby's still just getting that insulin response, and the sugar still just was up there. I mean, we're talking within like an hour of birth, this kid had a glucose less than 20 this week. And they're a lot of times hard to regulate because they just got pumped.
Did you say that was rare or not? Is that pretty rare?
It's not uncommon.
Not uncommon.
Yeah. We probably see.
My mom had 3 kids. Her 3rd child, she had gestational diabetes, and my sister was the biggest of all of us by like 3 pounds, and my mom is roughly my size. So, and then Grace was fine, but because my dad is a physician and my mom knew how to manage it.
Yeah. So I was like, if you manage strictly, you can.
Yeah.
A lot of people have really successful pregnancies. We typically see with neonatal transport not well managed moms.
Or they
But
be transported like that.
but I mean but you can't necessarily say like if your baby's sick and you had diabetes it's because you didn't manage it. I'm just saying there's those, but you can do things during your pregnancy to help with that. So maternal infection, and that can be from anything. Multiple gestation, obviously that's like one of our biggest risk factors is multiples always. Twins, a lot more likely to come early. We're looking at triplets and quads. We're looking at always early. The furthest gestation they'll let triplets go is 34 weeks. So you're looking at a guaranteed premature delivery if you have triplets or above. Because they don't let triplets go longer than 34 weeks. So, just for the safety of the mom and the babies, they just get. And then post-term gestation, you are actually as likely to have issues with a post-date baby than you are with a preterm baby. And the very sickest babies I have ever transported in my whole life are post-term babies. So they say 39 weeks is the ideal week to deliver, right? That's when your risk factors are the lowest for complications from being too early, and that's when the risk factors are the lowest for being born after delivery. Because at 40 weeks, your percentage of complication just ticks up and up and up and up.
I feel like we're all pretty familiar with what like a preterm baby looks like, but why is postterm, like what risk factors, what are we seeing with postterm babies?
So what starts to happen with post-date babies is the placenta is like, guys, I signed up for this to 40 weeks, and that's about, the placenta stops being as efficient. Okay. So you'll actually see babies in utero that are post-dates that probably have actually started getting not malnourished, but less nourished, because the placenta is just not as efficient, right? It starts wearing down, it starts getting all used up. The oxygen and blood exchange isn't as proficient at that point, and then babies start getting stressed, right? Like they were made to come out, and they're like, hey, I'm supposed to be out, and no one's kicking me out. Our bodies are pretty amazing at like naturally doing what we need them to do, but when babies don't get kicked out, they start getting stressed out, and their bodies are continuing to mature, but then that physiology change isn't happening. And the most, probably the most common detrimental thing that happens with post-term babies is meconium. They get so stressed out and they just don't handle things that well. They pass stool in the fluid, and that can cause so many issues.
At what point would the hospital require them to induce?
So they don't require induction.
Most
Most OBs will not let you go past 42 weeks.
Yeah.
But with that being said, I can't say, no one can say to me, you have to have that baby. Like, I'm going to make you come in, and I'm going to make you take tocolytic, and I'm going to make you contract,
But is there a point where it's going to be detrimental where you're going to end up having a stillborn? Because that's just...
Yeah, and it will happen. Hopefully naturally your body goes into labor, or you get uncomfortable enough, or but we have women who are like, I don't want to be induced. I don't want to be, or we have a lot of people who are more homeopathic and natural, who will then be doing, seeing midwives, delivering outside of hospitals, and they, I don't want to like put them all into a group, but as a general group, are a lot more bigger fans of allowing natural progression, and so are more against.
But then they call you to save them because.
Yeah, that happens sometimes, but like I said, 90% of babies are born without issue, right? And so for every 1% that we see that is a crash, burn, dead baby, you have to realize that midwife has probably delivered 10 successful babies for every one that we come to, or probably even higher than that, you know, just the way that things fall.
And then, one last question. Postpartum babies, is it more common with prima gravida, or?
Yes,
Okay.
because
The body's just not used to
yeah,
it.
multiple gestation is bigger. I mean, because once your body's done it, it's like, oh, okay, I remember this, so we'll kick it. But or like there's some, or once you've had one baby, a lot of moms know like I don't dilate. You know, I was in labor for 40 hours and then ended up with a C-section. So then they're a lot more likely to, with a second baby, just schedule their C-section or you know things like that. The other thing with postpartum babies is they're in there and they're getting bigger and bigger and bigger and bigger, and well, the size of the hole they've got to come out of is not changing size, right? So they get stuck, and then when they get stuck, you have compromises to oxygen. Because they're bigger and there's only a limited amount of space in there, there's a higher risk of cord accidents because they're out of space and that cord can get pinched, or as they're coming down, you know, their head or their body compresses it and they're bigger, there's just not the room to move around, so you're at higher risk for hypoxic injuries and things like that too. So no, if you know someone who's going post-date, be like, hey, maybe just get that baby out. And then polyhydramnios and oligohydramnios act a lot of fluid. So having too much intrauterine fluid or having not enough. So, and that can be caused by multiple physiologic issues. But usually these two things, either poly or oligo, do indicate that there's some kind of problem. There's something going on that baby's not cycling through that fluid, right? Because you guys all know how like fluid works. Yeah, they basically are cycling it and peeing it out, and that's how they're like. So kids that have polyhydramnios, a lot of times you'll see it with kids that have kidney issues, like Potter syndrome, that they don't have kidneys, or things like that, where they like the fluid just builds and builds. They're not cycling it. They're not. Or moms can have like a slow leak that just drain that fluid slowly and they won't even know that their water's ruptured and stuff, and obviously that increases your risk for infection but also decreases that amount of fluid. And babies, you know, moving and stretching it can cause some contortion issues and some things like that. So drug therapy, substance abuse, young moms and old moms, right? Moms that don't have prenatal care, they see a doctor at least once before you're 12 weeks. So that's kind of how we, if we say established like early prenatal care, that's prenatal care in the first trimester. Diminished fetal movement for any reason, babies that just stop moving, that's a bad thing. Fetal malformation, and then post-size dates discrepancy. So that would be like that glucose kid, right? If that mom didn't have any prenatal care and we didn't know that that baby was actually a 32-weeker and it's born and it's 7 pounds, we're going to have a really hard time like saying actually what gestation that baby is. So, and then just one thing on drug therapy and maternal substance abuse. So with drug therapy and maternal substance abuse, we're not talking just like heroin and meth and those kind of things, although we do see those fairly frequently in the NICU also. One of the biggest things and one of the things you may see, especially in Utah, is SSRI withdrawal in neonates. And it happens relatively quickly once they're born. Usually within a couple hours a lot of times, but because it's not a standard withdrawal like a narcotic withdrawal. Narcotic babies you can pick up from a mile away, right? They have classic symptoms, they have classic signs. I mean, I can walk in a room and be like, oh yeah, that's a drug baby. But SSRI kids, which are antidepressants and things like that, which are really, really common, especially in this area, we have found do have neonatal effect, and a lot of these kids come out having seizures. We have no idea why. They a lot of times follow a neuro-looking baby path. Like they come out and they just quite, their neuro exam isn't quite right, their reflexes aren't quite right. Like I said, they seize and things like that, so a lot of times they'll get transported. So we think they've had a hypoxic injury, we think, you know, we can't figure out what's going on, and they'll be okay for a couple hours, and then they just don't eat really well, they shake a little bit, they'll get jittery like narcotic withdrawal babies, but it's not the same kind of jitters. Does that make sense? It's more like a jerky jitter than like a shake jitter. And we have found that that is consistent with antidepressant use in pregnancy, and it's really common here. And the thing is that there's nothing we can do to treat it. You know, narcotics we can treat with morphine.
That's a big thing where you get the mom's history and stuff.
Yeah, and that's why maternal history is so important in neonatal medicine. Yes, having the maternal history, right? It's the only history we have. It's like as important as knowing someone's allergies, or you know, because that's all their history. That's all we know is what mom's been giving them and what they've been exposed to in utero. So, and that's our high risk OB line for 3, 2, 1 baby. So, premature labor, precipitous or early labor, chorioamnionitis, which is just an infection in the intrauterine fluid. Prolonged rupture of membranes, which we consider a prolonged rupture greater than 18 hours. So at that point, you're looking at just increased risk factors. Although a note on that, if we do have babies that are prematurely ruptured and they're premature, so predate, they will allow them to sit ruptured. They keep the baby monitor, keep the moms in labor and delivery, monitoring them and things like that. But I've seen kids sit for 2-3 months with the water broken. So it does increase complications. They mainly monitor the mom for infection, monitor the baby for having, you know, good fetal strips and stuff like that. Some of those kids have underdeveloped lungs. It does increase that risk of having underdeveloped lungs and things. But just because they're ruptured does not mean we're going to automatic deliver. If they're past 34 weeks, we'll basically just deliver them because the benefit doesn't outweigh the risk. But if they're less than 34 weeks, they will let them sit until 34 weeks, ruptured, as long as the body's holding them in and as long as they don't look infected, they'll continue to let them sit. So, and then a prolonged labor, that's anything greater than 24 hours of active labor. And then prolonged second stage of labor, which is pushing stage, which is anything greater than 2 hours, and then narcotic use within 4 hours. So obviously, with drug abuse, the closer to delivery time that the mom last used the drug, the baby will take longer to withdraw from the drug, right? Because it's recently in their system, just like a junkie. You know, they get their hit, and it takes a little bit of time. If the mom used the drug the day before, we may see it a little more immediate. So, and these are the kind of kids too that sometimes can make it out of the hospital if the mom does a good job of concealing that she's a drug addict. Because if they do it right before delivery, I mean, we've had moms in labor delays shooting up in the bathroom and, you know, stuff like that, that because the baby won't show symptoms for 24 to 36 hours, they can get out of the hospital in that first 24 hours if they've had an uncomplicated delivery. So then they'll go home. I think a lot of times they think they don't understand how serious it's going to be, but they'll go home and then the babies go apneic. Babies are jittering, screaming, you know, having all these narcotic withdrawal symptoms, and so we do occasionally see them come in through EMS because parents freak out, call 911, come get the baby. So, and then fetal bradycardia, non-fetal heart tones, non-reassuring heart tones, just any kind of variable that's like not working normal. Meconium stained fluid, where they have a bowel movement in the fluid prior to delivery. Prolapse cord, where the cord falls down. I'm sure you guys covered all of this in your placental abruption, where the placenta tears away from the wall, and a lot of bleeding is usually associated with that. And then uterine tetany, which is where they have, the tetany. It's tetany is where like they contract and it doesn't stop. So the baby's getting compressed and well, you know, the naturals like to compress, and it's normal to see like a little dip in their heart rate and stuff with compression, with a contraction, but it's like when that doesn't let up, it can lead to fetal bradycardia, and a lot of times, like it can be associated with prolonged decels, which is where they come down and they don't recover, and if it's going on more than about 2 or 3 minutes where that uterus is contracting and not letting out, it's sometimes an indication for an emergency C-section. Use of general anesthesia. We do occasionally, if you have a true crash C-sections, moms are usually just intubated right there on the table. But if mom has been intubated and under general anesthesia, then it obviously affects the baby. So, or we've had like moms in surgery for a non-pregnancy related surgery and then ended up in labor like during the surgery, and those kids come out. The longer they've been exposed to the anesthesia, obviously, the more it affects them. But, and then breech or abnormal positioning, which just inhibits like appropriate position for getting out, and then forceps or vacuum deliveries or emergency C-sections. So in the NICU, if a baby, if there's a mom in labor with any of these risk factors, if you're in a facility with a NICU, they'll give us a heads up, like, hey, this is possibly happening. Or outside facilities will a lot of times call to have teams come for the delivery. And I have flown to Wyoming for a 37-weeker with the mom comes in bleeding, an abruption. They can't transport the mom, so they can't do a high-risk OB transport, and they don't know how the baby's going to do, right? Mom's bleeding like crazy. They've got to get the baby out, and a lot of times they'll dispatch us to start coming. And I've gotten there, baby's born, looks fine, so we're just going to like, okay, we'll turn around and go back.
So vacuum delivery. Yeah, what is a vacuum delivery?
So a vacuum delivery is basically where babies are kind of stuck in their heads crowning, right? They have like an actual cup, like kind of vacuum. The suction cup, essentially, they put it on the back of the head and they pull them out, like with contractions. They'll wait for the contraction, they'll put it on, and they'll pull them as they contract.
Come out looking like a cone head.
Yes, they
Pictures
get
are
big
real great.
cone heads. It actually does increase their risk, though, of subgaleal bleeding. And can be, you're not supposed to, doctors, they have pretty stringent guidelines for using vacuums and forceps, but I have seen, unfortunately, more than one baby with a vacuum. You'll see the vacuum mark on their head basically get scalped. Because if that vacuum gets too much force or they're too aggressive with it, that it will just peel off their scalp. And the same thing with forceps. So forceps, it's a forcep, they go and they clamp the side of their heads with the forceps and pull them down like that, which can cause, if they're too aggressive, or a complication of those is like cranial injury from too much force, being cranial fractures, or nerve. I've seen babies get paralyzed, like nerve and brachial plexus injuries from being pulled like that. They're neck and shoulder injuries from being pulled.
Another random question. Okay, go ahead.
Can I still pack it?
Oh, yeah, sorry.
So,
Yeah,
when you
just
stick the
take that one
babies
over.
out the little padded helmet, why
Uh-huh.
are they wearing that? Is that competition with that, where they're trying to reshape the fontanelles, or?
They're trying to reshape their head, but typically what that is caused from is there are some cranial issues that you can't help. Most of that is just for positioning on the parent's side. If you look at your baby's head, if you take your baby's head and you hold it like this, and it's perfectly round and even on both sides, you're good to go. If you look at it like this and it's starting to get lopsided on one side, you've got to rotate that baby like babies favor one side over, just like I'm sure you have a favorite side to sleep on, or they naturally do that, but the thing is they do that and then they don't move. So if they do that over and over and over, it like
So it's a post-delivery complication?
it's a post-delivery
Okay.
complication. Yeah, and it's usually most of the time preventable
Rotate the baby?
if you rotate the baby, or you notice like one side's getting, or if you just intervene when it starts to become an issue. So they have to do the helmets and stuff when it gets really flat, and then there's like, okay, we're not fixing this, and obviously the kid's not laying on that other side, so they do the helmet to keep it there.
Is it just a cosmetic thing at that point, or?
Mostly cosmetic. Because the fontanelles, but it will be permanent. You'll see, if you see old NICU babies, they didn't, they laid in the same position for months, you know, and what we call NICU toaster head. A lot of our premature babies, because babies that are ventilated, right, we don't have the luxury of like just turning their heads. And we're pretty good at like manipulating it to give them time on each side of their heads, but they used to not. They used to put them in there. They were on the ventilator. You stayed towards the ventilator and you didn't move. And so we get like a lot of skeletal like issues, and people in adulthood that have flat backs of their head and make sure your parents did a good job. No, I mean, some people have naturally more flat, but I'm talking like flat backs of their head. And you'll see it with like a lot of times long-term handicapped kids that are in bed a lot. You'll notice like the back of their heads are a lot flatter. And then there's something else I was going to say and I don't remember. Oh, NICU toaster head is like, we'd see it a lot where the back of their head gets flat and then they look like they have a box face, because those are usually older babies, like we're talking like 25 years plus, that were on ventilators for a long time, and they were just always like this because the ventilator came here. They just kept them like this. A lot of times they'd put like boundaries and stuff on the side of their head because they didn't want them to move against the ventilator. And I'm sorry, they all have misshapen heads. So if you see somebody with a misshapen head, no, it's probably not their fault.
I want to ask you, because it's really insensitive to ask the parent, why has your baby got a helmet or a flat head?
Oh, yeah. You should now ask and be like, did you not turn that kid? What's wrong with you? I mean, and the thing is like lack of knowledge is a lot, you know? Like obviously, like those of us in the medical profession see a lot of things and go like, are you kidding me? But you have to remember, like, you don't know what you don't know, right? And if this is not a culture or environment that you're used to, then you just don't know, you know? I mean, I've had an occupational therapist in the NICU like, turn that kid's head, get that, you know, like, so you just don't think about it. So delayed cord clamping is now a standard of practice. So what delayed cord clamping does, if you think about it, you've got baby circulation going, you clamp off that cord, there's all that blood in the placenta still, there's all of that. So what delayed cord clamping does is it just gives that baby a little boost in hematocrit, and it gives them a little boost in, hopefully not too much because that causes complications also, but hopefully it just gives them a little boost in getting a little extra blood before they clamp that cord. So with a rigorous baby, it's suggested to also to help transition physiology a little better, right? When a baby comes out, you can check their pulse right on their cord, right? That's typically where we check it. You can feel that pulse really strong. And then the longer they're out, the less and less that cord, you can feel the pulse in that cord, and then it dries up and it falls off. And it's an open system when they're in utero, right? And so they think it helps transition physiology also to kind of delay the cord clamping. If we have this pulse, and then we clamp it off, it's a lot bigger shock to a system than letting it kind of tamper down and then clamping it. And it's a smoother transition. You know, if we're looking at like clamp, like bam, we're shutting, you know, we're closing off all those ductuses, we're expecting them to open those lungs. It's a really harsh physiology change. So it just helps that physiology transition a little smoother. And then cord milking rather than delayed cord clamping is where we're giving them actually extra blood. So because with premature babies, we take a lot of blood from them, right? They're at higher risk for blood loss. They're at higher risk for brain bleeds. They're at higher risk for just any kind of issue, blood loss issue. And most of it is like the NICUs take tons of blood from these babies, right? We try to be really cautious, but they require a lot of blood draws just to manage their, you know, so we know what we're managing and to adjust ventilators and things like that. So cord milking is where they actually will hold the baby below the level of the placenta and milk the cord down to give them that extra hematocrit boost. So, and then in the NICU with premature babies less than 30 weeks, we actually take their initial blood draws from the placenta. So in the NICUs, it's usually the charge nurses or one of the nurse practitioners are trained to draw blood off the placenta. And so we're trained to draw blood off of the placenta. So after the baby's born, we'll go in, draw blood off of the placenta to get an initial blood gas. So we kind of know like when they were born what their blood gas was sitting at, to get blood cultures, to get typing process for blood screening, and usually that's about it. But so that we're not having to take, so if you're talking about taking a blood culture, talking about taking type-in cross, and we're talking about, other tests like that. We're talking about 2 to 3 mils of blood, which if you're looking at 25 weaker, that's like about 1 kilo. Like, that's a lot of blood volume to be taking off of a baby.
At what point, because in that cord, that's like mom's blood and baby's blood, right?
Mm-hmm.
So how do you know if you're taking mom's blood or baby's blood? Yeah, but.
Oh, fetal blood versus maternal blood.
Right, I don't
so
know
we
when
draw
that
off of
works.
the artery because that's baby's blood. Because it like comes in and then circulates out. And it's not, the cord is not mixing mom's blood, that's baby's blood.
Okay.
Like it mixes in the placenta and filters through.
Okay.
It's just arterial and venous blood.
Okay.
So that's indicative of the baby.
Right.
So
That's really interesting.
So they really do like how we get a blood drawn, they do the same thing in the cord?
in the umbilical cord. We put central lines in the umbilical cord. We'll talk about that as we go. Good morning.
Does that not scan for right there? If they're taking antidepressants or anything,
If they're what?
can you get any of those blues, like what medication they're taking from that?
Yeah, so if we're going to take so they actually send segments of the cord. So segments of the cord is similar to like taking a hair follicle of like an adult, but we can only send it if we have suspicion without permission.
Is that pretty quick? If you have suspicion, do they?
Yeah, typically within 24. So all hospitals save the cord and placenta of every baby for 72 hours, and that's for reason of drugs and for infections. So because if we suspect that there was
They're not
a
gonna tell you, like you said.
yeah, if they do, then we send it just to verify, and if they don't and the kid starts having withdrawal, we actually, because it's like a child protection at that point, because the baby's actually born at that point, we can send the cord without permission.
Thank you.
That does test, but it is limited what you can test for on that. You can usually get types of drugs, but not necessarily specific drugs, so we'll know,
Yeah. Thank you.
So, any questions on cord clamping? Okay.
Just to review, don't we have to do it like 3 inches away from, or 10, or
So
what's
I thought ours was 4 inches
away from mom?
from the babies.
Okay.
So, and the other thing is like neonates, premature babies too are a little bit different than like full-term, I broke the placenta, than preterm babies too. Because what we will try to do with preterm babies, and especially if they're going to milk it, they'll clamp higher.
Okay.
They'll clamp higher, and then they'll milk the whole cord. Like that. And so you'll see when you get the baby this, you'll get a cord this long,
Yeah.
and it'll be completely like deflated.
That's really gross.
It's,
Yeah.
yeah, it is.
So,
But,
having you worked in that section, so pre-hospital we're told 4 inches. And
yeah, so, but if it's a premature baby, so here's what I'll say pre-hospital. If you have an extremely premature baby, please just do not clamp too close to the umbilicus. Because we do access that for like their IV access and things like that, we have to take it, we have to cut it off, and we need some manipulation area in order to get lines and things like that in. So just don't nub it off really close to the baby because it makes it really hard for us to get access to those lines. The more premature baby there is, the more I'd say give us cord, like, a couple inches of cord
Starbucks
is
says 4
fine.
inches.
4 inches of cord on the baby?
Yeah.
Oh, okay.
So that's what I was asking is once we bring the baby in with mom,
Mhm.
are you guys, if it's a healthy baby, going to clamp it? And
We'll clamp it lower and cut it off.
Okay.
Yep. You'd be surprised how many umbilical cords there are in the hospital trash cans. It's pretty gross.
The baby freezer's more scary.
Yeah, the placenta freezer in labor and delivery, or the actual baby freezer. Yeah, that's gross too. But in like all labor and delivery, yeah, there's usually like most labor and deliveries have like, and unfortunately a lot of times they're like in the dirty utility rooms and things like that.
So the breathing process will thaw, they'll bring up the baby until it thaws and then.
Yeah, and a lot of times, like, if you ever go in, like, an ER or, like, into a labor and delivery and stuff, and you walk past a door and there's, like, this weird, like, it's usually a butterfly, like, emblem on the, it's, like usually just, like, a 3x5 card with a butterfly on it, like, stuck on the, like, outside of the door. It usually is to indicate to staff and other people going in and out that there's like a dead baby in that room. So if you see one and you're going in there, just like, oh, hey, just don't let it freak you out when you go in. Staff. Yeah. So. What? Butterfly.
You think the butterfly means black?
Yeah, don't let it fool you. It usually doesn't.
Typical black butterfly.
It's like the science of the lamb's butterfly or moth or whatever.
Yeah, it's usually like dark. It's usually a dark purple or dark blue. It's usually like a dark blue or purple colored butterfly. So, anyway, I don't know why that was chosen, but that's just a way like to let other staff and stuff know that, like, so you don't get freaked out when you go in there. Yes. And like I was saying, they keep placentas and cords in labor and delivery for 72 hours because if we have complications with the baby, we can a lot of times go back and get the placenta. If we're suspicious of infection, like a baby at 24, 48 hours starts getting sick and we're wondering if there was some kind of placental infection, they could take the placenta and send it for pathology and culturing and see what kind of bacteria grows on that. And the same thing with the cord. We can send the cord for drug tox screens and stuff like that. It just saves the baby having to have a ton of blood draws in.
So if you have to do a blood transfusion with the baby and add blood, can they harvest blood from that placenta and give it to the baby, or you just, so you just use donor blood?
Donor blood.
What about mom's blood?
No.
May not make
We don't.
sense.
I mean, we just, because also, like most, when babies get blood, we give them irradiated and cytotoxic negative, CMV negative blood. Just because their immune systems are naturally compromised just by the essence of what they are, because they haven't had immunizations, they haven't had that. So we give leuko-irradiated and CMV negative blood.
When do you vaccinate babies?
So if they're full term, they can get their hepatitis B shot in the hospital, like pretty immediate after delivery, and then the next time for immunizations is 2 months, and then they just follow the standard immunization schedule. With premature babies, we don't give them any immunizations because we don't want to overload their system. They already have enough going on. Building antibodies is probably like, hepatitis B is probably not like on our top priority list, but they'll just get it. We do it by adjusted age. So a 32-weeker will get their hepatitis B shot when they're about 8 weeks old, or like when they would be term, because then they're about 40 weeks newborn period. So we have actual age, and then we have adjusted age in the NICU. So your actual age is chronologically how old you are. If you're a 23-weeker, and now you're 8 weeks old, you're 2 months old, right?
Yeah.
But let's do 30 weeks. That's a lot easier math. So if you're a 30-weeker and you're 8 weeks old, you're 2 months actual age.
Right.
But you're negative 2 weeks adjusted age, right? So we expect their milestones and their neurologic development and everything like that to fall in line with their adjusted age. So, and most premature babies should be able to catch up with their peers unless they've had severe complications between 2 and 3. So they count adjusted age until about 2 or 3, and then they should generally and then you'll start seeing like for sure deficit. So they say until 2 or 3, like if they're behind, they're not hitting growth charts. If they're not, on their adjusted age scale, we're like, they were premature. They just need some time to catch up. But once they're between 2 and 3, then they can start saying like, okay, so you're probably going to actually have a speech deficit. Okay, so you probably actually do have some learning delays, some developmental delay. So, get into resuscitation. Do you guys need a break, or do you want to go into resuscitation? You okay? Keep going? Okay. If you need a break at any point, just be like, hey. We need a solid break. Give us a break. So, yeah, keep on with the questions.
I just have a question. You go to like Riverton Hospital, I know they deal with a lot of little beats there, but will you, if they're sick, come pick them up from there and take them IMC?
Yeah.
So like I just recently, I blame it on this class because we're going over this stuff, but I went on a 21 weeks, she had feet coming out, and so we transported her quickly. She had pushed it back up in. She had about 4 minutes between contractions. And I just didn't know, like, when we got her there, it almost seemed like Riverton Hospital didn't like that.
Didn't like that you brought her there?
Didn't like that we brought sudden is an agreement, like, she's like, why did you bring it to this facility?
Oh. At that,
Here
well,
and
you're
there.
like, because it's an emergency,
Aren't
and
they out-
like last time we
outpatient
checked the
because it's
hospitals, like where we go in emergencies.
Exactly, I was just for my clarification, like, they
So-
should be able to handle something like that, right? You know, like.
Well, they don't have a level 3 NICU. So optimally, the best place for that mom to go would be somewhere with a level 3 NICU. However, the caveat to that is a 21-weeker is not viable. And anywhere.
Yeah.
A 21-weeker is not considered a viable infant. So if a baby is 100% not viable, you don't treat it like two patients. You treat it like we're treating the mom, and this is a medical emergency.
Gotcha. But, okay, but just for my understanding of the baby, just because it may have had a breakthrough place, still survives up there for
Yeah.
4 weeks until it is viable, right? Or is it most likely?
No, most likely at that point, if feet are coming out, chances are we'll have to deliver the baby.
Okay.
And chances are at that point, you're not going to be viable. 23 weeks is our cutoff for viability. We're talking 23, like 22 and 6, we're like, if we're really sure on dates, we're really hesitant to resuscitate 22 and 6. You know, like when you take a 90-year-old that's having a heart attack, and maybe this is correctly correct, and you're like, maybe you're like a little slow coding, you know, and you're like, how many ribs do we want to break before we have like a benefit to like risk ratio here? Well, the same thing is true just on the opposite end with neonates. We have a 21, 22 weekers. Parents are saying like, do everything you can. Please intubate. Please save this baby, without the understanding of the true ramifications and process that's actually about to take place. And like our whole thing, like do no harm, right? Like we want to save lives. We want to, you know, help people, but at some point it's futile. At some point you're causing more harm than good. And when you're looking at 21, 22 weekers, we're really looking at that. With that being said, I will also say that one of the very worst things we can do to premature babies is transport them. It significantly increases their risk of long-term impairment, of having brain bleeds. You take a baby that has really immature, fragile capillaries, and I don't care how careful we are, we put them in a helicopter and you watch their heads do this, right? Like, no system we have, no gel mattresses that we have come out with, no hearing protection, no, you know, we nest them in and we try to keep them as stable as possible, but we can't help but, I mean, you know, the vibration of an ambulance, the, you know, the movement of a stretcher.
You're talking about once they're out.
Once they're out,
Yeah. We're not gonna sit there and rattle them around to the hospital, so what do we do then?
But that's what I mean. If you are close, if a baby is, the mom's delivering a baby that you know is premature, and you are near a facility with a NICU, always choose that hospital. Like, St. Mark's has a NICU. You know, if it's a close call, it might be worth the extra 2 minutes to go to a different facility. You know? Or if we're looking like Altaview versus IMC, if they're like, if you're in the middle, if you're on 114th, then technically Alta's a tiny bit closer, but you know this is a 30-weeker, please go to IMC. Riverton has a level 2 NICU. So the difference, so here's where it gets tricky too.
So, do I go there?
So here's where it gets tricky with levelings of NICUs too.
Okay.
So NICUs are leveled, right? And a level 4 is what primaries is. Primaries is the only level 4 NICU in the state, which means that they can do ECMO, right?
Okay.
So a level 3 NICU is what
With the premium.
the other NICUs are, which is they treat anything 23 weeks and above. Anything 23 weeks and above, any viable infant. They can do ventilators, they can do pressors, they can do everything except ECMO.
That's probably why she was saying why we took her there, because she's 21.
21, yeah. But at that point, you can just say, the baby's not viable, we're treating the mom, this is the closest facility, this is the right call. I'd say you're absolutely the right call to go to whatever the closest is. You've got 21 weeker with their feet out, just go wherever and, you know, let cards fall with what may be. But
So the ideal obviously is primaries and then IMC and then you, right?
so primaries doesn't deliver any babies. be there.
So you
So
go there.
everything that goes to primary is transported in, right? We bring everything to primary, but the U has a delivery facility. So
You're IMC.
the U, IMC, Utah Valley, McCady, St. Mark's. Okay, here's the ones I screw up. The Pioneer Valley, the Jordan Valley West. What's the one on 90th South?
Jordan Valley.
Valley.
Okay, Jordan Valley.
You can say Jordan Valley and Pioneer, we know what you're talking
Okay,
about.
Jordan Valley has a NICU, a level 3 NICU. Pioneer Valley does not. Every time we get a page to those, I'm like, I don't know where we're going.
Why did they change names?
Is IMC trying to become a level 4?
No,
Or not?
no. Because, okay, so the reason for that too is because the very best way to keep a really, really specialized team proficient is to give them the highest volume. Because ECMO is a super uncommon practice, it, right, you don't do it, you lose the skill. So what we don't want is that dispersed out between all these NICUs and then have, you get one case a year, you get one case a year. It's way better to throw all the cases into the same team, have that team be really proficient, and they get to do it 6 or 7 times a year and stay proficient at it. It's the reason that we're the referral center for other states too. So every state doesn't even have an ECMO center. So we're the regional, the next closest ECMO center to us is Denver Children's or Stanford in California. So, like, and we just regionally break it up and take kids and babies to those facilities just to keep it specialized. So there's not a lot of level 4 NICUs. So
IMC is level 3, right?
IMC is a level 3.
West Valley showed up.
Didn't hear of it? Oh, West
That
Valley
is
showed up.
this.
I was like, didn't hear of it?
I mean, if you found a pen, I'd probably just put it in your pocket. Those are a hot commodity. So, to accurately not answer your question, it's like you have to do what's right for your patient, and you can't treat your mom based on the what if of the baby, right? So if mom is imminently delivery, if you are, you know, she's crashing, she's like whatever, then you just got to go where you've got to go, and then it'll just be taken care of how it gets taken care of, right? But if you are in the middle of like 2 or you're close, you know, like we've had tons of moms, like we had a mom like, oh, Timpanogos has a level 3 too. But we'll have like a mom picked up in like Orem who is like, no, my OB is in American Fork Hospital. Take me to American Fork when you're right between Utah Valley and American Fork. You know, they're like, and like I said, you don't know what you don't know, right? Most people don't know the levelings of NICU. Most people don't know. Well, guess what? If you're 30 weeks and I take you to American Fork, you're either going to get transported again, which we're talking about cost, resource, everything with that, or you're going to have your baby out there, and then we're going to take your baby. And we're going to take your baby to Utah Valley, and we're not going to take you. So, you know, but you do get, I mean, you get moms, which if anyone has been pregnant or knows someone that's been pregnant, you get, I mean, moms are super loyal to their OBs, right? For good reason. I mean, they followed them, they know, they feel comfortable with them delivering. Mom's worst nightmare is to have like her OB gone when she delivers, right? And have some random person walk in and deliver you. But in an emergency situation, like if you're in Orem and she's saying like go to American Fork, you're gonna say you're going to Utah Valley. So, and usually if you say to a mom like, we'll have to transport your baby and then we're gonna leave you there and we're gonna take your baby away, most people will be like, oh, okay, take me wherever I need to go. So, so with neonatal resuscitation, so I mean, resuscitating babies is the same principles as resuscitating adults, right? Like the ABC is the same for babies and adults. So you want to make sure that airway is open and clear. Make sure the breathing is spontaneous or assisted if they're not, and then make sure the circulation of oxygenated blood. So babies, I mean, 99.99% of babies are born, they have strong hearts, right? They're like they're brand new, right? Everything's new, everything's fresh, everything's strong. So usually you're not having babies go into cardiac arrest because their heart is failing. You have babies going into cardiac arrest because they are not getting adequately ventilated. So we cannot stress enough with neonatal resuscitation that the very most important thing is to ventilate the lungs. You do nothing else, ventilate the lungs, and everything else gets fixed when you ventilate a baby. It really does. If the baby comes out with no heart rate, if you bag that kid effectively and can get those lungs open, you'll just see that heart rate shoot, 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 shoot. It's the reason why, like, the 1% that needs, like, extensive resuscitation, so I worked in a level 3 NICU for 12 years before I went to Life Flight, and I probably pushed epi in the delivery room twice. So we're talking, like, if you adequately ventilate and you get these kids breathing, very rarely will you ever have a cardiac arrest that cannot be, like, that needs medication intervention. Most of the time, as soon as you get them ventilating, their heart rates just shoot up. Even kids that come out with no heart rate, if you adequately ventilate their lungs, you'll get a heart rate back. You know, they have strong hearts. That's the other thing you'll see with kids. I mean with babies. If you have a baby too that you're gonna withdraw support on, like, just know they're gonna kick it for a while. Like, their hearts are strong and they are new and they just kind of don't stop, you know. Babies naturally just don't do much. They regulate their vitals and they regulate their temperature and they eat and poop, right? So, like, their brain stems are really high functioning, so they also, you know, on that level will, you know, have a pulse, have a stuff for a really long time. Still don't expect it to be like older patients where, you know, you pull them off the ventilator and they pass away really quickly. They can, because, so in utero too, babies are satting about 40 to 50% in utero. So you have to know too, like, they come out blue, right? That physiology changes and their oxygen levels are going up, 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 up. But they're used to being in an environment of low oxygen content. So it's also not like us that's been out kicking it and breathing for a long time in this lovely 21% air. You know, they've been satting 40 to 50%, and so they tolerate a lot more. They'll tolerate hypoxia a lot better than you or I, or our kids will. So the 3 vital questions to ask if you go to a neonatal delivery is, what's the gestational age? We kind of talked about that just so we know kind of what we're looking at as far as, like, size, physiology, things like that. Do they have good tone, and are they breathing or crying? So, tone always seemed like a weird question for me, like it to be one of the things. But if they have good tone, then chances are they're moving, they're not bluffing and circulating. Usually if they're moving their extremities, then they're circulating better. Yeah.
Kind of random on what I was talking before. Where her contraction is most likely fraction is.
If you had feet out, then no.
But no, that was it.
Yeah, Braxton Hicks are like false contractions.
I was just wondering if it was just causing false contraction if the baby wasn't liable, or would it have been alive at that moment? So.
It totally depends. I mean, if the baby, you can have feet out and the baby will still be alive. The other thing with, like, babies that small too, this sounds super gruesome, if they are backwards and their feet come out first, I unfortunately have seen it once, and only once, thankfully. But babies that small, if they come out in bad position and their feet come out, their heads are stuck up in, and that cervix naturally clamps down, and that cervix will actually strangle them, or we have seen actually a cervix clamped. You know, it's a strong muscle, like, and it clamps and it's tight, and can actually, a baby that small, decapitate them. Oh my God. So if you have a baby in bad position, that's probably why they pushed it up. Like, because a baby that small just can't tolerate. Also, once, like, they're out, that's why heads are meant to come out first, because that physiology starts changing and things. So, I'm not saying that it's not viable. There's also physicians that are really proficient at pulling babies' breech. They have to be fast and they have to be good at it. But 21 weeks, they're not viable. So the baby may still be alive, that answers your question, but the baby's not viable. So even if it comes out and takes a breath and breathes, we can't intubate, we can't appropriately ventilate. Their central nervous systems are just too immature. Their physiology is just too immature to be viable. So they may be alive, but they're not going to live. Does that make sense?
Yeah,
that's how we, like, rank viability. So they may come out and take a couple breaths. You know, we've seen 19, 20 weekers that have come out and, like I said, they have a strong heartbeat, they have, you know, they're trying to breathe. You can see them kind of trying, but we can't do anything for them.
I shows on a whole lot of those calls. So
Yeah. No, absolutely.
So it's a full decapitation most of the time, or is it just like a partial where this breaks the spine out?
Well, so luckily I've only, like I said, only been involved in that one time. But it can be either. It can like kind of strangulate where it just kind of clamps down, and then they have to, I've actually seen them have to go in and cut the cervix, like, which is like the most gruesome sound you'll ever heard, is women having their cervix cut. Like, they'll go in and like cut the muscle to release it enough to get, in an extreme emergency. Obviously that compromises that woman's body for like any future like use. But they will, in extreme circumstances where a baby's like being strangulated and stuff in there, like go up and clamp and cut the cervix to release the head. Because otherwise it will continue to clamp down
What
and
did your baby do?
cause actual like full decapitation.
Oh.
So no, it clamped down and we couldn't get the baby out, and they cut her cervix to release the baby, but the baby wasn't viable.
I have never had children. It's not a bad thing, it just sucks when your body's like
I say, but remember the statistics. 90% of the time, it goes just fine. And like, even with that 99% of the time, they just need a little kickstart and we can do it. We're talking about like the extreme 1% here. We're talking about extreme cases. This is like worst case scenario. Horrible things that happen that no one talks about that most likely won't happen to you. You've got a 99% chance that none of this will happen to you.
Well, I'm still not. She's like, ah, thank you.
So if you want to be super paranoid when you're pregnant, work in a NICU while you're pregnant.
I was gonna ask, do you have kids?
I have 5 kids actually, and it
How
will
old are
make
you?
extremely. I'm 34. It'll make you extremely paranoid. But
I bet.
You have
Yeah,
5 kids?
I do. Plus like 3 bonus kids, so I have actually like I help wrangle 8.
Wow.
My husband has
Bonus
3.
kids. You're a badass.
Thank you.
Surprisingly.
That's usually not the reaction. Usually the reaction is like, 8 kids, what are you doing, lady? Like, yeah. No. But,
That's good.
yeah, I have 5 of my own, 3 bonus. They're great. We like them. My husband is so oddly enough, my husband is a neonatologist.
Oh, wow.
And so you want to see really paranoid people,
Right.
then come and meet us.
Right.
So he's dual board certified. He's a neonatologist and a pediatric intensivist. So you want to, and then I do life flight, pediatric neo. So if you want to see super paranoid people that don't let their kids do anything, you can come to our house. All right, children that can't get on ATVs, can't jump on trampolines, and
I had a neighbor that was.
it's sad.
I was growing up once they were home, and I totally get it now.
Yeah.
Like when I was 8, I was like, why? Why is it there then? But now it's like trampolines are not safe at all.
Yeah. And my husband's like whole reasoning for that is because like if someone gets hurt on our trampoline and we have to take them to the ER and they'll be like, you two do what? Yeah, he's like, it's really a safe space for us, not really for the safety of the kids.
Right.
My neighbors had a waiver, I used to have to sign, or my mom had to sign.
So you want to evaluate all of this and intervene in what we call a complete assessment in the golden minute. So that first minute of life is really crucial to initiating neonatal resuscitation. So, and we're talking like, as soon as the baby's out, start counting that minute. And we're talking by the time the doctor clamps, and by the time that all happens, even on like really sick kids that they're moving pretty quickly, chances are the first time you're going to get eyes on that baby is probably like 30 seconds. Unless you're the one catching it, and then you can get it right as they come out. And but I just mean by the time you even take them out, clamp and lay them down to assess, they're usually about 30 seconds old before you can even assess them. So, and like for you guys, great place to put the baby, up on mom's abdomen. Just like if you don't have somewhere, you know, if you're in an ambulance and she's delivering or whatever, just pop that kid up there.
That's common practice to keep them warm too, right?
Yeah, it is common practice to keep them warm with resuscitation, with like emergency resuscitation. Like we have done that before, like just pop them up on mom to get like, at least like get some kind of eyes and assessment. You just have to like tell them mom like, we're gonna be using your stomach for a second, just don't touch and don't forget the stomach.
You're not ventilating the baby and stuff on top of the mom.
What was that?
You're not ventilating the baby and stuff on top of the mom?
Yeah, I mean if you're in an ambulance and you have a baby come out, you may, I mean if it gives you more space and it's more, just wherever is reasonable, you know. obviously it's our ideal not to do that, but you know, if you're delivering a baby on the side of the road, you're already in like less than optimal conditions. So the same thing if they, because you guys will probably get called to like scenes for moms that like deliver in a car on the side of I-15 or you know, stuff like that. And if you don't have like a lot of space, or say mom's bleeding and babies having a hard time too, you've got to take mom too. A lot of times you'll take them together, you know, just to get quickest places, resources, whatever. Then you just kind of do what you can do. You know, I've seen babies ventilated like carrying like that. I've bagged a baby in the back of a car, like, you know, you just kind of do what you can do to get those lungs open, because at this point we're talking about you've got to get that heart rate up, you've got to get the lungs ventilated. So whatever the quickest way to do that. We're not looking at optimal situations here like hospital deliveries. We're just making do with what we've got. That's like EMS in a nutshell, right? Like we're super good at like MacGyvering everything that could possibly be MacGyvered and like using things for
a lot of things.
What?
Diesel fuel treats a lot of things.
Duct tape, diesel fluid, like it's good. It's in all of our survival packs, right? What do we have? So just making it work. Using like non-commercial use is like our specialty, right? For using equipment and things like that. The other thing is I've seen like a shoelace broken off to tie a cord off. I've seen, you know, like you don't have a delivery kit, you don't have cord clamps, like anything will do. I had a baby delivered in the hospital roundabout and we didn't have the cord clamp kit, like, because we were actually downstairs and the dad just came running in the door, so we ran out there. The baby's out. I was like, we need something to clamp the cord, and the dad grabs his boot, like broke off the shoelace. I was like, all right, that'll work. Like tie it off, you know.
I was totally expecting to say he like bit it off or something.
Don't put it in your mouth. Yeah, like we should still follow like the general rule of like.
It's not yours.
Yeah, don't do that. Blood transmitted infection.
Can you cut
Oh.
it?
Like for sure.
I wouldn't do that either. I would not tie it in a knot either. I would actually tie it with something. And make sure that it's tight and secure, because the other thing is if that, whatever you tie it with, which is why we use clamps, but if you have hemostats in your pocket, pull it in hemostats. Like that's actually awesome, hemostats. Yeah, but just make sure that doesn't come off, because that baby will bleed out rather quickly and die if you don't tie that cord securely.
So you're talking about baby comes out, you have full syringe mouth, and then the nose, because a lot of times we do the nose first, we do the top,
They
they
do.
might just suck all that crap
Because
in.
they naturally.
Because they're naturally going to be blue. And then all of a sudden, if that doesn't stimulate them, then you're talking about the resuscitating them back.
You'll be able to tell pretty quickly. If you dry and stimulate a baby and they don't start crying, no amount of drying and stimulation is going to make that baby cry. So that's what we call secondary apnea. Babies are apneic at delivery, right? They come out not breathing, and we stimulate them. That causes those physiologic changes. But if a baby comes out, and when you stimulate them, they don't start crying or breathing, gasping, they're not going to do it for you. You can tell within about 10 seconds of stimulating them. If you're not seeing some kind of respiratory movement, they're not going to do it. It's called secondary apnea. No amount of stimulation will fix it. You've got to ventilate the lungs through bagging.
But every birth you should almost have that already. Expecting the baby is not free.
Yeah, like every delivery, like at the hospital, we have the warmer wards, we have bags and masks ready to go, just in case. Like say you're working in non-optimal conditions, so just know. Yeah, so just know, like if you know, like ahead of time, yeah, and just be prepared for that. So, but just remember, 90% of the time, we're going to transition nicely. 90% of the time, it's going to be okay, right? 90% of the time, it's going to be okay. Just remember that. 90% of the time, if you provide warmth, clear the airway, and dry and stimulate, your baby's going to be fine. Okay? 90% of the time. Majority of the time. Just keep thinking that. It's not that scary. Most of the time, it's going to go okay. Right? It's like the 1% sheer terror that keeps you like in it, right? The adrenaline of it. We all like it. I know you guys are all adrenaline junkies too. You don't do this job if you're not. We all live for the 1%. So yeah, just routine care. Clear the airway, like you said, mouth before nose, and then dry and stimulate them. And most of the time they'll start to cry.
What does bilirubin mean?
It is the liver. It's Yeah, it's basically broken down. It's also broken down by the liver.
Oh.
It's a byproduct of red blood cells. And if the livers are immature and don't break it down well enough, or they have a lack of vitamin D and stuff, then it builds up and up and up in their system. And high bilirubin levels can lead to neurologic damage.
And that's what they'll look jaundiced if they have high bilirubin?
Yeah, so when they look yellow-ish. And babies that have like weird antibodies and stuff like that and can't break it down and their billies keep climbing, and even with the lights it can't break them down, we actually end up what we call an exchange transfusion, where we take out their blood and put new blood in.
Oh.
Like that doesn't have the billy in it, so that their bodies, so that they're basically offloading the liver to be able to break down those red blood cells. So usually that's what causes it in like really, really high billy kids is like antibodies from the red blood cells, like weird antibodies. Mom had weird antibodies.
I think I had that when I was born because my parents called me bilirubin.
Well, we're glad
That's
to
messed
see
up.
we're glad to see you've made it to adulthood.
Yeah.
So they used to like before they had like the billy like the glow sticks and stuff like that. They used to just say like take them and put them in the sun. And they'd put them in the sun.
Yeah, I had to be under some sun lamps for like a couple weeks.
Yeah, it's really progressive now. They used to be like just put them out in the sun. Then it became like there was like a suitcase with like kind of looked like a mini tanning bed. They'd have them leave them in that. Now they have like beds that you can take home that you can like.
It's like
They have like.
Yeah, that's
Yeah,
literally
I
what
like
mine
that.
looks like. I'm in like a little aquarium.
Yeah, that's what they
Little
look
lights.
like. They look like little glow babies. And
my
now
God.
they have, but you have to like keep their eyes covered and they're like
Yeah.
little sad. Keep them
They
naked,
glued
keep
a
their
mask
eyes
to my
covered. They're
face.
like little sad souls. But now they have like billy blankets, which is actually like a blanket that you tuck in their blanket and then swallow them. They don't have to be like, if it's low enough, if it's high enough, they have to be hospitalized, and then we keep them naked and put them under all the lamps. But
So, if I have Gobert syndrome, which means my liver doesn't process it well, so I always have a high bilirubin count. Is there a way to tell in infancy or neonates if they have that versus just their liver's not working well?
I don't know at all. I'm sure lab would work, but I don't know. Sorry, I'm not familiar with that. I don't know the answer to that. So, is your baby crying? This is a good sign. If your baby is crying, so then you just need to assess what is the color. Remember that they're going to be blue in the beginning, and that's normal. And acrocyanosis, which is their hands and feet, are still blue, and that can be normal up to like 24 hours because that circulation is all changing. Not like blue, but like a little blue tinge. You know, like when your hands are super cold and they look like they're not perfusing well. That's what they're doing. They're not perfusing well. You know, obviously they're shunting to vital organs. That's the most important thing their body's taking care of. But if they're getting pinker, if they are crying and their color is improving, then just let them be. So once they're breathing, you can provide free flow oxygen if they continue to have cyanosis. But just remember, like they've been statting 40 to 50%, they're going to come out looking like they're statting 40 to 50%. They're super blue. And they should be continually improving. And then just remember to provide supportive care, and above all else, keep them warm. So babies have, you know, big heads, a lot of exposed surface areas, and they lose heat really, really quickly. And when babies get cold, we just cause a lot of problems for ourselves that can be avoided by just simply keeping them warm. Like they just want like the basics. They want to be back in like their warm little contained area, so just keep them warm. And you'll prevent a lot of issues for yourself. So for free-flowing oxygen, so you can't give free-flowing oxygen with a self-inflating bag. With the flow-inflating bags it will, but the self-inflating bags can't give blow-by. That makes sense. Like, so the best thing to do is, and like a lot of like adult cannulas are way too big for these kids, but you just like just get some oxygen near their face, then you're good. And like just cupping it, like you can see in the picture, like getting an end, even cutting off the cannula end, so you just have like the actual cannula part off, so you just have like a tube, or using the tube from a bag or whatever. Then
what liters per minute are you flowing to do that?
So usually like 2 to 3. If you're just giving like blow-by, like just 2 to 3 liters a minute is fine. So, and yeah, because they usually don't take very much. And if they're like breathing well, because if you're giving blow-by, they're breathing on their own, right? Their colors just needs a little help. If they're breathing fairly comfortably, but their colors if they're just slow to pink, just give a little blow-by to help them pink up. Obviously, if they're having severe respiratory distress, we're going to intervene differently. But we're talking about kids that are like, come out, they're crying, they're breathing, they just aren't pinking very quickly. Just give them a little bit of oxygen and it'll help them pink up. So they say, like in NRP, neonatal resuscitation, they say give them up to 10 minutes to get to like a sat of 90. So, and if you're ever going to put a sat monitor on a baby, do you guys know where you put a sat monitor on a baby?
The toe?
If you can,
Toes.
at all. No, if you can, at all possibly, and you have like a posy sat or like, you know, like that, right hand. Always on the right hand.
What?
So it's a preductal sat, which best gives you the saturation that their brain is getting. So because of the ductus in babies, you won't get really accurate, and they obviously have flow compromise. Their feet are going to be lowest flow. So if you can, hands, more specifically right hand, because if whatever their sat is on their right hand is what indicative of the oxygen their brain's getting, which is the most important thing. So just if you ever put a sat on a kiddo, on a baby, and that's specific to newborns. Like kids, stick it wherever you want, you know, or whatever. But on a newborn, on a neonate, right hand. We only put sat monitors on the right hand in resuscitations. So for like big fat healthy babies, right, our natural want is to like wrap them up and like, yeah, right, we want to like keep them warm and wrap them up and all those things. And it kind of comes instinctual, you know, like moms want to hold them against them, and you know that's fine, and they're breathing and that's cool, like do that. But it's kind of instinctual to do that with a fat healthy baby. What we do forget is teeny tiny babies, because they come out, we stick them down. We don't want to stop looking at them because we think they're going to turn blue and die on us, right? So we kind of leave them exposed. But because they're wet, they're small, and they have relatively large head to body ratios, they get cold super, super fast. And like I said, cold, stress, in a baby causes you a whole grundle of issues that you don't even want to deal with, right? We're dealing with enough here, we don't need to deal with anything that we can prevent. So don't forget on tiny babies, like to keep them warm. It's one of the most important things. Ventilate their lungs, keep them warm, you'll be all right. It's kind of, you know. And that's the other thing with like resuscitating on mom's chest. If they're like stable-ish, even if they're still having some distress, but you can reasonably accommodate it, like using mom as a heater is actually really helpful. It's direct skin-to-skin contact, but the mom's body will naturally like transfer their heat to the baby. So obviously we have to have some exposure to like access them and get them out. But a good thing to use on a really tiny baby that you still want to be able to see, but and assess, but want to keep them warm also is put them in a plastic bag.
The baby.
Mm-hmm. So in the NICU resuscitation rooms, we actually keep a box of gallons of Ziploc baggies. And if we know we're getting any baby less than 30 weeks, we cut the bottom of it and like undo the zip part and put it, and then when they come out, we put them on the bed and we wrap them.
Because it's see-through.
Because it's see-through, so you can still assess them.
Got it.
You can see them, you can assess them. But also, if you know a kid's really premature and that you're most likely going to need to bag them and stuff like that, you're not doing a lot of like dry stimulation. You're putting them in the bag, and that actual moisture will help continue to keep them warm. So just put them in the bag, zip them in the bag, and then like we cut the bag
Right.
so that you can open it like that.
Right.
And still access them when you need to get access to it. But so don't like take the zipper, don't put them in like the top like and seal them.
And zip it shut.
Yeah, but like cut it down the middle and open it and zip them in. And we do that, like we'll do that in the resuscitation room, and then when we take them to the NICU, we'll have one in the warmed bed, and then we'll transfer them over to a new plastic and wrap them up. So, and we'll keep like babies like 28 weeks and lower, we'll keep them for like 72 hours in plastic wrap. So
You just have a thing in the
controversial saran wrap.
Yeah, saran wrap will work. Anything like
So-
anything will really work. Saran wrap, it would be great. And put a hat on their head if you have one, even if it's giant, bigger than their head. Put a hat on them if you can. You don't feel free to like use heat packs too to keep them warm. Crack a couple heat packs, put it under them, especially if you're assessing them and stuff. Put them just under the back of them, but just don't put it directly on their skin, obviously. Let's see. Yeah, so babies are likely to lose heat through conduction, convection, evaporation, and radiation. So, takeaway point from this, they lose heat really quickly. It causes a whole bunch of issues. There you go. So, cold stress is detrimental. We can't stress it enough, really. Providing warmth and ventilating the lungs, like I said, are like, if you take nothing away from neonatal resuscitation other than those two things, like, I'm happy. So, it does increase their development of acidosis because their bodies are just doing everything that they can to keep them warm, right? They're kicks up their metabolism rate, they're burning off sugar, they're using all their energy, their oxygen consumption decreases because they're having to circulate faster to try to keep their bodies warm, and they just get more and more acidotic because of the increased metabolic rate and the increased oxygen consumption. So we'll see kids that like are having dips in their sats, like, you know, they'll start dipping in the 80s and we're like, what is going on? And they're cold. Like they just can't keep it all together. You warm them up, they do just fine. So normal temperature for a neonate, 36.5 to 37.5, using plastic wrap, plastic bags, caps, thermal mattresses, body contact, and just like if you're in the back of an ambulance, well, it's unfortunate for us, cranking up the heat in the back of the ambulance will just help increasing their environmental heat. So you can sit in the sauna while they are at normal temperature. So, but it's also vital to avoid hyperthermia, which is greater than 38. We check axillary temps on babies to get temperatures. But hyperthermia does the opposite, right? It vasodilates everything. It can increase the blood flow to their head and things like that. And on really premature babies, hyperthermia puts them at higher risk for brain bleeds and things like that because we're vasodilating everything. And they just have fragile capillaries.
Does that go for adults too?
Hmm?
Does that go for adults too?
I'll be honest with you, I know nothing about adults.
Okay.
Let me be 100% honest with you. The last time I dealt with adults was in nursing school. I came straight out of nursing school into the NICU, and now it's just been way too long. I don't remember. I don't know. And all I do is neopeds, so sorry, I'm not helpful. I just don't want to give you misinformation. Be like, that neo nurse, I feel like she doesn't know. So symptoms of hypoglycemia. So if you see a kid with any of these symptoms, actually check a sugar. If you pick up a baby, check a sugar. So just check a sugar. So ventilate their lungs, keep it warm, check their blood sugar. Those are awesome things. So jitteriness, they just get super jittery, which a lot of times too, like the jitteriness can even look like drug withdrawal and stuff. You'll be like, oh, this is a drug baby. Oh, just kidding, it's a hypoglycemic baby. Sorry we accused you of doing drugs, Mom. Like, have you taken anything during your pregnancy? They're like, no, I wasn't on anything. You're like, yeah, right. We're skeptical of everybody. It's like people who say they don't beat their kids, right? Like we all believe, we know that they do until we prove that they don't. That they look jittery, like even, like, have you guys seen the, like, drug withdrawal jitteriness? Like, it looks, that does look the same in babies as it does in adults. That, like, they look like crackheads, I don't know what better. Like, but they're just totally jittery and shaky, and they're, like, tremoring, and, come on, you guys are EMS, you're probably more familiar with crackheads than, like, right, like, okay. You know what that looks like, right? So, but, like, that kind of jitteriness, and you'll think that they're in withdrawal, and then you check and their sugar is, like, 20. You're like, oh, okay, just kidding, we just need to give you some sugar. Hypothermia, so that's where we're, like, the sugar, having a low sugar can make them cold, and being cold can make their sugar drop, so it's kind of the double-edged sword. So babies that are just lethargic, like having poor tone, poor feedings, apnea, cyanosis, high-pitched cries, and seizure. So you can see, like, the hypoglycemia stuff does look a lot like drug withdrawal and and some of those other things. So hypoglycemia is really prevalent, way more prevalent in neonates than in any other population, just because just the natural makeup of their physiology. So they don't have a lot of extra fat store, right, to break down, to keep their sugars up. They wear out really quick, they have decreased glycogen stores, and they have really quick metabolisms. Babies that are small from gestational age, babies when they're born, because they're not going to be getting a ton of nutrients that first couple days, right? Like, their moms don't produce a lot of milk the first couple days. And so they use, and it's common for all babies basically lose weight right after they're born, right? Like, that's why they check it every day in the hospital, because we know that they're going to lose weight. Like a 5 to 10% weight loss in the first 4 days is totally normal for a newborn baby. But it's because they take that fat, the last 4 weeks of pregnancy, basically all that baby's doing is storing fat. So they say they gain approximately like a pound a week that last 4 weeks of gestation, which is also why it's really important to try to go to term, right? Because they gain a pound a week, and what they're doing is just putting on fat stores for this time when they're born, and they need to break down that fat, metabolize all that brown fat, and use it because of their decreased glycogen storage. They need to use that to keep their blood sugars up and to sustain those first few days of life where they're not going to be getting much nutrients. So that's why sick babies and like premature babies are at way higher risk of having issues with hypoglycemia because they haven't put on that fat, and and then we talked about already like infant of diabetic moms because they've been exposed to all that sugar, and we just cut off their candy supply, so they're not happy about it. So, and then stressed or sick infants just have that increased metabolic demand just because their body's just fighting to maintain homeostasis. So they just their metabolisms are increased, so they naturally burn through their glycogen stores a lot faster. So, against all like what you want to do not feed a hypoglycemic baby. So, because like their body's fighting to keep that glucose up, right? What does your body naturally do in like fight or flight? And when you're sense stressed, shuts down like that blood supply to your stomach. So we don't feed hypoglycemic babies. And also for babies, we tolerate a lot lower glucose parameters. So for a baby, a glucose 45 and above is considered normal. So if you see a glucose of 50, you're like, okay. Those kids totally feed them, like their glucose will come up. It's like less than 45, like we don't want to feed them. You probably don't want to feed them while you're transporting and stuff. But if you can get IV access, a 2 ml per kilo bolus does the trick. So, and that's just quick IV push, IV flush, fast push. You don't have to give it slow. I mean, on any tiny baby, you should give everything slow, but not like, we're not talking about putting it on a pump and running it slow. We're talking about just pushing it and get the sugar in and flush it. So, what do you guys carry with you though?
D50.
D50. Please don't ever give D50 or D25 to a neonate.
Dilute it? Is that
You can dilute, so yes.
Some of the rates of these.
So standard neonate fluid is D10. Like, I know you're not going to have D10, but we can make D10, right? Or D12. Let's just go D12. If you have D25, dilute it out 1-to-1. Make yourself some D12 and a half, and just give that. No one's going to follow you for that. But do not push D25 or D50. In these babies, it is caustic to their veins. If we have any infant we have that needs a concentration greater than 12 and a half, we put in a central line. We don't give fluid greater than 12 and a half. It just destroys their veins. So, if you just remember that, 2 per kilo, push it, and just make sure you dilute it. You'll be good. 2 per kilo. 2 mils per kilo.
25 grams per kilo IVIL on her.
For the dextrose?
Not good.
Is that D50?
Yeah.
So that's probably why. If you dilute it down, then you're giving a lot smaller concentration because you're giving a lot higher concentration of glucose. So if all you have is D50, just give that dose of D50, but then super dilute it out. Put it in a 10 ml syringe and dilute it out. So. You know what I mean?
Yeah.
Just don't give straight D50.
Yeah.
You know, dilute it out, which then makes it less concentrated. So,
That was very good.
yeah. Yeah. So, yeah, just don't give D25 or higher as a report. Alright, we'll take like a 10-minute break or so. And then just flush it out. Yeah, I mean, whatever. Yeah, it's just a lot more complicated. So, and because they usually, I mean, standard IV gauge in babies is like a 24. We have a 24 gauges in neonates. So you're looking at like a tiny diameter anyway. So if you push it and then you blow your vein and and then you're looking at like tissue necrosis, and then you're looking at if you have a hypoglycemic kid, then you're unable to treat the hypoglycemia because you don't have your vein access. Like I just recommend looking it out.
Oh, yeah, sorry. No. I have one. One of the people who was in here today wants me to bring her one.
Yeah.
Hi, Kylie.
Hi!
How are you?
One more.
So we're doing our NRET and our testing on the 30th.
Right.
The practical.
Right.
Practical. I report that day. I report that morning for custody of my child.
Okay.
I think court starts at 9, but I don't know officially what time they call because it's like she brings in like 100 people and
Right.
she just calls them up one by one.
Right.
So I mean I can go and come back, but that's my issue. Yeah, I have court.
Okay, let's talk to Captain Burge.
Where have we gotten so far, Terrence?
Okay, we got everything okay.
I don't know. I mean, like, yeah, like it'd be fine.
We need
It's
to
just
talk
getting like a
again
it's not
with
like
Kylie.
because you have like split custody right now. No.
Well, she's got a little issue with the 30th.
I have to report to finish up my divorce and get custody for my child. I know. I wasn't want to join.
So I'm gonna have to kick you into the next class. So you can be reviewed next day.
Okay.
No, wait a second. You can be reviewed Monday, a day early. And then we're Tuesday. No, another morning. From 8 to 3. Roughly. Sorry to call you so short. Will you send me an email?
I am so
Why?
I know.
Oh, yeah.
Okay, let's talk.
Okay, yeah. It's funny. I took notes down on my phone when I talked to her.
Well, Jared can come in with us too, because he's got some of the same issues.
Yeah, so
Karen's got all kinds of issues.
so she was like, Kat, she walked me through how to like make my application.
Oh, I'm sorry.
Yeah, that's okay.
Should have told you that before
Oh, no, you're
we
fine.
started.
Yes, Chris.
Right down the hall on the right, almost in the hall.
Oh, hi.
Anything else you
Yes. Sure.
They are.
That makes it way easier.
Okay.
I think this is one of the biggest classes we've had.
I think we have everybody here but
Everybody
Nicole.
but Nicole.
Yeah.
And that's really weird because Nicole is here probably 95% of the
She's
time.
working today.
Yeah,
Still.
yeah,
Yeah, it's fun.
yeah. Maybe she's streaming.
She tried, but it's not working.
What?
Yeah.
No, that's
Oh, man. It says it's working.
She said that she went online and it's not streaming to the YouTube channel.
Okay.
But I have a packet to bring her later.
Okay.
I'm gonna just go ahead and see if she can drop it off for us.
Well, it's recording,
Right.
so.
She worked all the 24 for you?
Yep.
That's good then.
Where are you calling
You know what?
Oh, no.
Stop that.